Welcome to Eye Care Central. In this video, we will talk about a very commonly encountered ocular condition known as pterygium. Pterygium is also known as surfer's eye, though there is no evidence that it is seen more commonly in those who are involved in water sports. In fact, the word pterygium is derived from the Greek word pteryos, which means wing. That is because the shape and the structure of a pterygium resembles the shape and structure of the wing of an insect. Pterygium is a degenerative disease of the conjunctiva. It extends from the canthal region of the bulbar conjunctiva, crosses the limbus, and then invades into the superficial cornea. A pterygium is triangular in shape. It is a raised lesion. The color of a pterygium is usually pearly white or pink. It is located within the interpalpebral fissure. Interpalpebral fissure refers to the space between the upper eyelid and the lower eyelid. So typically a pterygium is located either at the 3 o'clock position or the 9 o'clock position of the eye. Pterygium is seen more commonly on the nasal side of the eye. Sometimes a double-headed pterygium may also be present, which means that an eye contains both a nasal pterygium as well as a temporal pterygium. But isolated temporal pterygium is extremely rare, and if you see a patient presenting with an isolated temporal pterygium, it should raise a suspicion of malignancy, and that patient should be referred to an oculoplastic surgeon. A pterygium could be unilateral, which means it is present in only one eye, or it could be bilateral, which means it is present in both the eyes. If it is bilateral, it is usually asymmetric. That is, one eye has a thicker and a more vascular pterygium compared to the other eye. Sometimes the pterygium evolves from another very common degenerative disease of the conjunctiva, which is known as a pinguecula. Pinguecula is a small elevated yellowish mass that is confined to the limbus and the bulbar conjunctiva. It does not invade the cornea, but like a pterygium, it is also located within the interpalpebral fissure. The prevalence of pterygium varies from 0.7% to 3.1% in different parts of the world. It is seen most commonly in countries that are located near the equator. Pterygium belt refers to the regions that lie between 40° north and 40° south of the equator. These regions characteristically have very dry, hot, windy climate that is said to favor the development of a pterygium. The incidence of pterygium is highest in those between 20 to 40 years of age. It is extremely rare in children who are less than 12 years of age. The main risk factor responsible for the development of a pterygium is believed to be increased exposure to ultraviolet light. Thus, the incidence of pterygium is higher in those who work outdoors, like farmers, or those who work in certain factories like welders, etc. Other risk factors are male gender, because males are the ones who are more involved in outdoor activities and thus they are more exposed to dust and other irritants than the women. Presence of dry eye. So tear film abnormalities may cause localized drying of cornea and conjunctiva, which can predispose them to new growth. There may also be a genetic predisposition. Pterygium is a degenerative disease of the eye. The type of degeneration that is characteristically seen in a pterygium is known as elastotic or elastoid degeneration of the conjunctival and the subconjunctival tissue. So what does elastotic degeneration mean? Just like true elastic tissue stain positive for elastin, the collagen fibers of a pterygium, they also stain positive for elastin. However, the enzyme elastase that can break down true elastic fibers, it cannot break down the fibers of a pterygium, which means that the fibers of a pterygium are resistant to the enzyme elastase. Thus, the fibers of a pterygium have some properties that resemble elastic tissue, like staining positive for elastin, but they have some properties that are different from true elastic tissue. That is, they cannot be broken down by elastase enzyme. Thus, they are not truly elastic, hence they are termed elastoid or elastotic. So, these fibers can be precursors of elastic fibers or they can be abnormal matured elastic fibers. Along with elastoid degeneration, there is also present intense fibrovascular reaction. This fibrovascular tissue proliferation extends from the bulbar conjunctiva and invades into the superficial part of the cornea, destroying the Bowman's layer and the superficial stroma of the cornea. The pathogenesis of pterygium is not clear. Like I mentioned before, the most accepted hypothesis for the formation of pterygium is increased exposure to ultraviolet light, more specifically ultraviolet B light. UV light stimulates the proliferation of fibroblasts and increase in the concentration of local growth factors. UV light may also cause damage to the limbal stem cells which act as a barrier, and this damage may lead to invasion of cornea by the conjunctival tissue. Another hypothesis is that the UVB radiation causes mutations of p53 tumor suppressor gene, and that causes abnormal proliferation of limbal epithelium, and that gives rise to a pterygium. Exposure to UV light could explain why pterygium is seen more commonly on the nasal side of the eye. The reasoning for this nasal affinity is that because of the shape of the eyelids, the nasal conjunctiva is more exposed to UV radiations than the temporal side of the conjunctiva. There is present bowing of the outer two-thirds of the upper lid that covers the temporal conjunctiva. Also, less subconjunctival tissue is present in the temporal region as compared to the nasal side. Thus, we can say that less tissue is available temporally that can proliferate into a pterygium. A pterygium can be divided into three parts: the cap or the apex, the head, and the body, also known as the tail of the pterygium. The cap is the leading edge of the pterygium that lies on the cornea. It is firmly adhered to the underlying cornea. It mainly consists of fibroblasts that invade the superficial cornea. The head lies behind the cap and it is also attached to the cornea. Unlike the cap, the head is quite vascular. The body refers to the part of the pterygium that lies on the bulbar conjunctiva. It is mobile and it is easy to dissect. That is because it is not stuck to the underlying sclera because of the presence of the Tenon's layer between them. Sometimes pigmented iron deposits can be seen on the cornea just in front of the leading edge of the pterygium. This feature is known as Stocker's line. Stocker's line is a punctate yellowish-brown subepithelial line that passes vertically in front of the apex or the cap of the pterygium. It contains iron deposits arranged in a linear fashion. A Stocker's line forms in a stable pterygium, that is, it indicates a lack of growth. Thus, if a Stocker's line is present, it usually means that the pterygium has been stationary for a long time and is unlikely to extend further into the cornea. Pterygium can be classified into two types: progressive pterygium, which is thick, fleshy and vascular and progressively encroaching towards the center of the cornea. The second type is regressive pterygium, which is also known as atrophic pterygium. It is thin, it is atrophic and it has little vascularity. In fact, with time it may become membranous. However, a pterygium never completely disappears. Clinical features of a pterygium. Pterygium is asymptomatic in early stages. The patient may have symptoms of dry eye, like gritty burning sensation. That is because pterygium makes the ocular surface uneven and that can disturb the tear film. As the pterygium progresses, it may become a cosmetic problem. If it encroaches onto the cornea, it may disturb vision by inducing astigmatism. Pterygium gives rise to with the rule astigmatism as it flattens the horizontal axis of the cornea. In extreme cases, pterygium can affect vision if it encroaches into the pupillary axis. Also, diplopia may occur either due to induced astigmatism. In that case, it would be a uniocular diplopia. Binocular diplopia may occur if a thick fleshy pterygium causes restriction in ocular movements. Very rarely, a pterygium may undergo malignant transformation also. Management of a pterygium. There is a lack of consensus amongst ophthalmologists on the management of pterygium. The treatment can be conservative or it can be surgical. In cases of early or atrophic pterygium, the patient is put on conservative management, which consists of artificial tear drops, vasoconstrictors and anti-inflammatory drops. Indications for surgery. Pterygium is operated upon if it encroaches onto the visual axis or if there is a high likelihood of encroachment. If the astigmatism induced is large, if it causes motility restriction and diplopia, if it is a cosmetic blemish. Pterygium excision may also be considered in patients who insist on wearing contact lenses. In patients with significant astigmatism before cataract surgery, especially in those who are being planned for premium IOLs, keratometry values stabilize 1 month after pterygium surgery. It should also be excised if there are clinical signs suggestive of neoplasia. The excised tissue should always be sent for histopathological examination for confirmation of diagnosis. The main worry after pterygium excision is recurrence of the pterygium. The risk of recurrence is different for different surgical procedures, and we will talk about each one of them in detail. First is the bare SCLERA technique. So in bare SCLERA technique, the pterygium is excised and the cornea is scraped of all the fibrovascular tissue. But the conjunctival defect that is created after pterygium excision is left as it is, that is, it is left uncovered. That is why it is called bare SCLERA, because nothing is used to cover the underlying sclera. This area of defect is allowed to fill with scar tissue with time. It is believed that this scar tissue may prevent recurrence by acting as a barrier to any conjunctival regrowth from reaching the limbal area and eventually crossing over to the cornea. However, this technique has a high recurrence rate ranging from 24% to as high as 89% and is not really recommended. Other complications of pterygium excision include corneal scarring, corneal perforation, strabismus due to injury to medial rectus or due to extensive scarring that occurs postoperatively. Another technique for pterygium removal is avulsion of the pterygium. In this, the bulbar conjunctiva over the pterygium is incised and the body of the pterygium is freed from the underlying sclera. Then this freed portion of the pterygium is grasped with a tooth forceps and it is pulled and torn away from the cornea. Any tissue remaining on the cornea is scraped off and the surface is then polished with a diamond burr to make it smooth. So in this technique, no dissection of cornea is done. The supporters of this technique claim that it is a simple surgery and it avoids accidental deep dissection into the cornea. However, just like bare SCLERA technique, the recurrence rate is high at 23% to 75%. Excision with primary closure. In this, the pterygium is excised and then the margins of the conjunctiva are sutured together after making relaxing incisions on both sides. Some surgeons may also create a superior conjunctival rotational flap. The recurrence rate of this technique is low at only 5%. Transplantation of the head of the pterygium. This technique involves transplanting the head of the pterygium away from the cornea, that is usually beneath the superior edge of the adjacent normal conjunctiva. So in this technique, the pterygium is not excised, but its head is repositioned away from the cornea. The advocates of this technique believe that it is the head of the pterygium that is responsible for its growth into the cornea. And if this head is transplanted to another area and the original area is covered by the conjunctiva surrounding it, this normal conjunctiva may act as a barrier to the regrowth of the pterygium. However, no data is available on recurrence using this method. Conjunctival autograft technique. This technique was described by Keenan in the year 1985. So in this technique, the pterygium tissue is dissected and it is excised. And then the defect is covered with a conjunctival autograft. Autograft means that the graft is taken from the patient himself. So the autograft is usually obtained from the supratemporal bulbar conjunctiva and then it is used to cover the sclera. For successful procedure, it is important that the underlying tenons is carefully dissected from the conjunctival graft. There should occur minimal tissue manipulation. The orientation of the graft should be epithelial side up. The recurrence rate with this technique varies from 2% to even 40% according to some studies. So there are three ways by which the conjunctival graft can be attached at the area of defect: by using sutures, by using fibrin glue, or by using autologous serum. Sutures that are used are usually absorbable nylon sutures. Suture-induced complications are suture infection or suture abscess, granuloma formation, chronic inflammation, fornical contracture, ocular motility restriction, scleral necrosis, and buttonholing of the graft. Some people advocate the use of fibrin glue to attach the graft. Fibrin glue is a blood-derived product that consists of two parts, fibrinogen and thrombin. Thrombin activates fibrinogen and converts it to fibrin, which acts as the tissue adhesive. It acts as a tissue adhesive within 30 seconds to 1 minute of application. Fibrin glue has been shown to reduce recurrence rates. It provides better post-op comfort. There is reduced surgical time, better cosmesis and better hemostasis. However, it has a potential risk of prion disease transmission like parvovirus B19 and even anaphylaxis reaction in certain individuals. Also, fibrin glue is costly. It is not easily available in many parts of India and it must be used within 3 hours of preparation as it degrades very rapidly with time. Third approach is to use patient's own blood for tissue adhesion. This is known as conjunctival autograft with autologous blood. There is no question of availability as the blood that oozes out during surgery is allowed to collect in the area of conjunctival defect and then the conjunctival graft is placed on it. This procedure is far less expensive than fibrin glue. There is minimum risk of disease transmission. Conjunctival autograft technique is not feasible in certain situations like large conjunctival defects, especially in extensive dissection or in double-headed pterygium. Also, conjunctival autograft is avoided if the bulbar conjunctiva needs to be preserved for future glaucoma surgeries. Limbal conjunctival autograft is quite a recent technique and is a modification of the conjunctival autograft technique that we just discussed. The procedure is similar except the limbal conjunctival autograft contains the conjunctiva along with approximately 0.5 mm of the limbal tissue as well as the peripheral corneal tissue. We know that limbal epithelium contains stem cells. These stem cells generate new corneal epithelial cells in addition to inhibiting conjunctival epithelial invasion of the cornea by acting as a barrier. The recurrence rate varies from 0% to 15%. Patients who have undergone multiple pterygium excisions with extensive damage to the limbus may benefit the most from this procedure. Next is amniotic membrane grafting. The mechanism of action of amniotic membrane in preventing pterygium recurrence is not clear. Its basement membrane may have anti-inflammatory and anti-fibrotic properties and it may promote reepithelialization of the cornea. Recurrence rates vary from 2.5% to 10.7% in primary pterygium. Primary pterygium is a pterygium that has never been touched surgically. However, in recurrent pterygium, it could be as high as 37.5%. The AMG is placed with basement membrane side up and stromal side down. Some studies have found its results to be comparable to conjunctival autograft. Some have found to be less effective. Also, AMG has less impressive cosmetic results. It is advantageous in situations where the bulbar conjunctiva may not be available for grafting or it may need to be preserved, like large pterygia with large conjunctival defect, double pterygium, scarred conjunctiva, and glaucoma patients who may need to undergo trabeculectomy in future. Mitomycin C is an alkylating agent that inhibits DNA synthesis leading to cell death. It inhibits fibroblast proliferation. Mitomycin C or MMC can be used in two forms. It can be used intraoperatively by direct application to the scleral bed after pterygium excision. There is no consensus on the effective dosage of MMC. It is mostly used in 0.02% concentration or 0.2 mg per ml, applied for 30 seconds to 2 minutes followed by profuse irrigation with saline. Some studies advocate 0.01% concentration, some advocate 0.03% concentration. It can also be used post-operatively as topical MMC eye drops. Complications of MMC, it can cause necrotizing scleritis, scleral calcification, corneal ulcer, corneal edema, iritis, glaucoma, cataract, and hypotony by causing damage to the ciliary body. Because of these complications, it is advisable to avoid MMC use in conditions that are known to cause severe ocular surface dysfunction like Sjogren's syndrome, severe keratoconjunctivitis sicca, severe meibomian gland dysfunction, severe blepharitis, acne rosacea, atopic keratoconjunctivitis, uveitis, neurotrophic keratitis, or herpes simplex keratitis. The treatments that are done along with pterygium excision surgery to reduce the chances of recurrence and to increase the rate of success of the surgical procedure are known as adjuvant treatments. So conjunctival autograft, limbal conjunctival autograft, MMC, amniotic membrane graft, they are all considered adjuvant treatments. We will briefly discuss a few other adjuvant methods as well. Use of cautery. Cautery is applied to vessels at the scleral bed and the vessel surrounding it. Since the growth of the blood vessels at the operation site leads to the recurrence of a pterygium, cautery may provide some benefit. However, there is no data available on the risk of recurrence. In fact, excessive cautery may lead to the development of hypertrophic scar tissue, scleral thinning, and scleral necrosis. Next is laser therapy. Argon laser spots are applied to early neovascular fronts. The recurrence rate is approximately 12%. In some studies, excimer laser has been used to ablate the irregularities in the bare scleral surface after pterygium excision. The recurrence rate was 91%. Complications of laser therapy include scleral necrosis, scleromalacia, secondary iritis, and cataract formation. Beta irradiation. Strontium-90 is the type of beta irradiation used. Beta irradiation inhibits the mitosis of rapidly dividing cells. It acts on the endothelium of developing vessels and it causes obliterative endarteritis. It also arrests fibroblast proliferation. No clear-cut recurrence data is available, though it may range from 0.5 to 16%. The adverse effects of beta irradiation include prolonged conjunctival hyperemia lasting for weeks to months, scleral necrosis and scleral melting, iritis, corneal ulceration and corneal perforation, endophthalmitis, sectoral cataract formation because beta irradiation damages the equatorial cells of lens epithelium. Thiotepa. It is a radiomimetic agent because its mechanism of action is similar to beta irradiation. It causes obliteration of newly formed vessels by acting as a mitotic inhibitor of capillary endothelium. The complications include prolonged conjunctival hyperemia, formation of pyogenic granuloma, and permanent depigmentation of the eyelid skin. Topical steroids. Topical steroids inhibit inflammatory reaction that occurs post-pterygium excision surgery. They prevent the growth of new vessels. The regimen is to use topical steroids 4 times a day for 2 weeks after the corneal epithelial defect has healed. 5-FU or 5-fluorouracil. This is a pyrimidine analog that interferes with DNA and RNA synthesis and it inhibits fibroblast proliferation. The recurrence rate is quite high at about 25%. Topical anti-VEGF monoclonal antibodies. VEGF or vascular endothelial growth factor is one of the growth factors that is found in increased concentration in pterygium tissue. It promotes the growth and proliferation of new vessels, so anti-VEGF monoclonal antibodies can bring down the levels of vascular endothelial growth factor. Topical anti-VEGF monoclonal antibodies can be used as subconjunctival injections or even as eye drops. The injection of anti-VEGF is given in the body of the pterygium. The anti-VEGF agents used are bevacizumab and ranibizumab. They may help in reducing the thickness of the pterygium and also in reducing its vascularity, but they don't have any impact on the size of the pterygium. It is also to be noted that anti-VEGF monoclonal antibodies are not FDA approved for ophthalmic use. Treatment of recurrent pterygium. Recurrent pterygium occurs after surgical removal of primary pterygium. Unlike primary pterygium, its development has no relationship to ultraviolet radiation. It probably occurs due to accelerated fibroblast proliferation that is caused by surgical trauma. Virtually all postoperative recurrences occur within 1 year, often within 6 to 8 weeks of surgery. That is why it is important to examine patients for several weeks and months for signs of recurrence. Recurrent pterygium is more difficult to remove because the tissue planes are distorted and the scar tissue could be strongly attached at various places like the rectus muscle or the corneal stroma or the scleral bed. Recurrent pterygium can be treated with limbal conjunctival autografts that we discussed earlier. Other techniques are keratectomy and keratoplasty, sometimes combined with adjuvants. In keratectomy, the lesion is removed, the vascularized cornea is scraped clean, and the granulation tissue is also removed from the scleral bed. Then beta irradiation may be applied to the scraped area. Lamellar keratoplasty or partial thickness corneal transplantation is reserved for cases where previous pterygium surgery might have caused thinning and scarring of cornea. In very rare cases of multiple surgical interventions with marked corneal thinning or impending perforation or marked corneal scarring that might be causing obstruction of the visual axis, these cases may need full thickness penetrating keratoplasty. So this was all about the management of pterygium, but can you prevent a pterygium from forming in the first place? Unfortunately, there is no proven method of prevention. One can limit exposure to UV light and dry and dusty environments. Some ophthalmologists advocate wearing UV blocking eyewear. Close-fitting wraparound sunglasses may also help by protecting the eyes from both the dust as well as the radiation. A major differential diagnosis of pterygium is pseudopterygium. Pseudopterygium arises from damage to the limbal or the peripheral conjunctival epithelium due to various causes like chemical burns, marginal corneal ulcer, cicatrizing conjunctivitis, trauma or surgery, etc. So the adjacent conjunctiva migrates to the injured area and it becomes adhered to it. Pterygium is different from pseudopterygium in various ways. Pterygium is a degenerative process. Pseudopterygium is an inflammatory process. Pterygium is more commonly seen in adults, while pseudopterygium can occur at any age. Pterygium is located horizontally and most commonly nasally. Pseudopterygium can be present anywhere on the eye. Pterygium can be distinguished into a cap, a head, and a tail. Pseudopterygium does not have a defined structure. Pterygium is commonly progressive, but it can be stationary also. Pseudopterygium is always stationary. Pterygium is adhered to the limbus. Pseudopterygium is free at the limbus. If you try to pass a Bowman's probe under the pterygium at the limbus, you will not be able to put it through. However, in a pseudopterygium, a Bowman's probe can be passed under the pseudopterygium at the limbus because it is not attached to the limbus. Pseudopterygium can be removed by surgical excision. Pinguecula is another differential diagnosis of a pterygium. It is a small, elevated and yellowish mass. It is confined to the limbus and the bulbar conjunctiva. It does not encroach on the cornea. It is located in the interpalpebral fissure. It is mostly asymptomatic. Sometimes it may become inflamed. Surgical excision of a pinguecula is rarely indicated. Unlike a pterygium, a pinguecula does not recur after surgical removal. The prevalence and the incidence of pinguecula increase with age. Pinguecula is common in both temperate as well as tropical climates. Exposure to ultraviolet light does not increase the risk of developing a pinguecula. So with this, I would like to conclude this video. Please like it and share it with your friends and colleagues if you found it useful, and please subscribe to my channel to support free education. Thank you very much.